Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friends. Welcome to this week's episode of the Healing Pain Podcast. This week, we're joined by physiotherapist Carolyn Vandyken, and we're discussing how to implement effective pain education and other psychosocial interventions into the practice of physical therapy and others who are helping people with chronic pain. Carolyn has been a practicing physical therapist specializing in orthopedics and pelvic health for approximately 3 decades. In addition to being a licensed physiotherapist, Carolyn is also certified in the McKenzie method, is certified in acupuncture, as well as a certificate in cognitive behavioral therapy. In addition to clinical practice, Carolyn is heavily involved in postgraduate pelvic health education, research in lumbopelvic pain, speaking at numerous international conferences, as well as writing books and chapters on pelvic health, orthopedics, and pain science. On today's episode, you'll learn why pain education is essential for the treatment of chronic pain, as well as how to implement other biopsychosocial interventions, such as cognitive behavioral therapy, acceptance and commitment therapy, and mindfulness for the treatment of chronic pain. Okay, without further ado, let's begin and let's meet Carolyn Vandyken. Hi, Carolyn. Welcome to this week's episode of the podcast. It's great to have you on.
Hi, Joe. Thanks for having me. I'm excited to be here.
I can't wait to talk to you about all the things regarding pain education, both for people living with pain, as well as the practitioners that are starting to learn about pain neuroscience education, starting to implement it into clinical practice, and use it as a form of education for people with pain. As you know, on this podcast, we speak to both people who are living with pain as well as practitioners. I want to start, and I want us to speak to someone living with pain right now, because pain education sounds kind of funny almost. Like, why, if I'm in pain, why should I tune into a podcast episode on pain education? So I'm wondering if, in your own words, you can first describe what pain education is, and then why that's important for someone living with pain.
That's a great question, Joe. And I think that it's at the heart of what we do, I think, as clinicians in 2020. And, you know, we've had evidence over the last probably 15 years or so that we need to start to educate our patients more about the pain system and how it works. And one of the ways that I start with almost all of my patients is to actually go back and look at the International Association for the Study of Pain, the definition of pain. And so I don't say, oh, hello, Joe, it's nice to meet you. Come on and sit down in my office. Let me tell you about the definition of pain. But I really start with, you know, they always fill out a fair bit of paperwork for me because I really want to understand both their physical complaints, but also their distress and their psychosocial, their lived experience of pain and what's going on. And I'll put that down on my table and I'll just say, hey, Joe, just tell me a little bit about your story. I want to hear in your own words what's going on. And when they start to talk about pain, and almost always, I would say my patients within the first 20 minutes or half an hour start to say things like, you know, when I'm really stressed, my pain is worse. And that's a great opportunity for me to say, well, can we explore that a little bit more? And then I'll say, let's talk a little bit about what pain is exactly. So when we look at the definition of pain, pain is a sensory and emotional experience. And I'll stop there and I'll say, why do you think it says and the definition and not or, right? And so pain is always sensory. We feel it in our body. And it's always emotional. There's always an emotional distress sort of component to that. And so we need to think about pain not only from its physicality and what's going on in the tissues, which is how we've been trained to think about pain in more of the biomedical model, but also the kind of sensory, or the emotional component to that. And you know, when they start talking about when I'm stressed, my pain is worse, it just gives us a great opportunity to link those two phenomena. And so if we go on to look at the definition of pain, pain is not only sensory and emotional, but it protects us from harm. So when we injure ankle when we run across the street and fall into a hole and sprain our ankle, and we tear ligaments. So pain is produced then to protect us. But pain is also produced to protect us from potential harm. That's the other piece of the definition. So when we've had pain for a long period of time, which is what many of the people that are listening to this podcast who are experiencing pain often are kind of stuck in this loop of pain. What they need to understand is that pain is also produced when the tissues are approaching harm, or the brain thinks that the tissues are actually potentially going to be, stressed too much, or challenged too much, I guess is the best way of putting that. And so we can get pain even though the tissues are healthy. And that's an important concept. Pain is an output. Pain is produced by the brain. Pain is not produced by the tissues. And that's 100% of the time, whether it's acute pain or persistent pain. And the other piece of that definition that I think helps patients to understand why we need to delve into pain a little bit more and understanding it is because it's always described in terms of damage to the body. That's the last part of the definition. So even if there is no harm or damage or injury to the tissues in this moment, and you have pain, it always feels like the tissues are being injured or damaged. And so that's, I think, why we as clinicians and why patients get stuck with treating tissues and really trying to look for a tissue-based explanation for pain. But that often comes up short. And that becomes very frustrating for clinicians and very frustrating for patients who seek MRIs and other tests to try and understand what's going on.
Wonderful way to start this episode. So let's rewind for people. And let's just kind of revisit some of those bullet points, because oftentimes people are listening in the car, or they're on a treadmill, or they're cooking dinner. So pain is both a physical as well as an emotional experience.
Right.
That's first. Pain is about protection. That protection could be with regard to a recent injury where there's actual tissue damage, or that protection could be about potential damage when that damage or injury has not occurred yet. And then finally, pain feels like damage, but with regard to chronic pain, that's not necessarily the case.
Great summary.
Right.
Yeah.
And it's nice to kind of bullet point things for people, because I think, as you and I both know, we've been practicing this for a long time. Pain is a wonderfully fascinating thing to us as clinicians, those of us who are really into the pain neuroscience and of course into helping people clinically, but learning kind of to like break this down for patients to make it simple. Okay, now I have these 5 bullet points. That's one thing we can discuss during the initial evaluation. It may take someone a week or months to really figure out what that means to their particular life context, but you mentioned the lived experience of pain. We should add that in there too.
Right.
And then we start to build out that lived experience for people so they understand, okay, here's what my pain is about. And here's how I can move forward with your help as a skilled licensed clinician and overcome what's happening.
Right. Yeah, it really is about understanding the context, isn't it? The context of the person who's living with pain in their life, and so what was happening at the time that the pain started and what's been going on since that time. Because, if you are suffering right now with persistent pain, you're not alone, right? 1 in 4 people continue to have pain after the injury has healed. And one of the things that we need to remember is that tissues heal in 8 to 12 weeks, full stop, right? So if we have an injury, our body is incredibly capable of healing itself. But then when pain goes on, after that healing timeframe, it often becomes a pain system problem. So it's the pain system that's the problem. And that's why pain education is so important. If we can understand that system and how it works, now we have another way into their experience of pain to help them desensitize that experience or change that experience in a way that either helps them to live more functionally with the pain, or even better, helps them to desensitize the pain system so that they can go on to live a happy and productive life without pain always rearing its head when there's only potential tissue injury involved.
Okay, excellent introduction. I love it. And you can, of course, rewind that, or you can actually go to the podcast website, and all that is transcribed. So everything Carolyn said there is transcribed. You can literally read through that and copy and paste it for your patients and clients, and of course yourself. Carolyn, there are of course physical therapists who listen to this podcast. They're familiar with the concept of pain neuroscience education. For maybe those few potential PTs who aren't quite sure what this is or why I should be implementing pain neuroscience education as an intervention into my practice, or maybe there's a nurse listening or another practitioner who is a little bit outside that realm of information. Why is pain education so important as a first-line intervention for people living with pain? So why should we be using pain education in clinical practice?
Right. So first of all, I think if we look at evidence-based or evidence-informed practice, we do have level 1 evidence that educating patients about the pain system and how it works is one of the one of the strongest strategies that we have for people in pain. So first of all, there's good evidence behind it. Adrienne Lau's meta-analysis in 2012 is one that we can point to, but there's many other studies that have been shown to demonstrate that teaching patients about pain is a helpful intervention. But it is not, it may be the starting point, but it cannot be the stopping point, right? Mm-hmm. So one of the things that we need to do is recognize, yes, there's good evidence that we can teach patients about pain and it will change their pain experience. But if that's where we stop and then we just go on to treating the tissues, then we're doing, I think, ourselves a disservice and our patients a disservice in that process. But I think that's often where we get stuck, because most of our ongoing sort of education in PT, for example, for sure, is still very tissue focused at this point. So we have good evidence that understanding the pain system, how it works, can change pain, but it's a jump off point.
I love that. So it's where we start, but it's not necessarily where we finish with people. So in essence, if I'm reading kind of into this, Carolyn, what you're saying is there is potentially some practitioners who are on board with pain education, pain neuroscience education, explain pain, and they start using that in their evaluation, or maybe they use it in the first couple of sessions. But then there's almost like this flip of the switch where the rest of the treatment continues along a more traditional biomedical approach or biomechanical approach, if you will.
Correct. I think that is the transition period that we're in. So as I mentioned, and as you know, we probably have 15 or 20 years of some research behind us around the pain system and the importance of, I think, again, certain patients understanding the pain system. I'm not a firm believer that everyone gets the same sort of pain education talk and I just sort of give the same information to every patient. You really have to tailor it to what that person needs in front of you, which means that you really need to understand, if you're a clinician, pain education as well as you understand anatomy and physiology of a joint, right? And I would say in Canada, so I'm Canadian, in Canada, I would say that is not the case. I would say that most Canadian physiotherapists do not understand pain education to the level that they understand anatomy and physiology of a joint. And so we tend to default back again to what we're comfortable with, and that's human nature, right? What have we been trained in? Sort of body as a machine, biomechanical sort of approaches. And so even though the person in front of us may be presenting with persistent pain, and we know there's more going on. We've been trained to look for yellow flags, for example, which are, again, those distress markers that we talked about that may be affecting pain. However, we haven't really been trained to intervene with those yellow flags. And so we default back to what we know, which is treating the tissues.
Which can be very confusing for a patient, I would imagine.
Right.
So as you have, and this is not a judgment, of course, all of us have made mistakes in our career.
Yeah.
The reason why they call it clinical practice is because you learn new things and you put it into practice, and hey, this works really well with a middle-aged man with chronic low back pain, but this didn't work so well with an elderly woman who has a hip fracture, let's say.
Right.
And you learn how to tailor, which is really what personalized pain medicine is all about. However, it's so interesting for me to think that all of us are really on this continuum with figuring out how to implement PNE, and then, as we'll talk about soon, adding that plus onto it.
Right.
So now that we're using pain neuroscience education, where do I start to kind of taper down that pain neuroscience education and then start to add the 1+2+3+ other type interventions that are going to help with that chronic pain, or what we kind of know as a sensitive nervous system on this podcast.
Right. So I think to start with, I'm a big proponent of the using sort of questionnaires to really assess distress, we're going to call it, that emotional sort of component of pain, right? And I always find it very interesting. I love that you said we're all on this continuum, because we are. And I say, it was sort of 2008 where I jumped into my first pain course, and that was 12 years ago. So curiosity sort of kept me going and kept me interested. But I'm still on this continuum. I'm a McKenzie credentialed therapist. I still use those skills in my practice every day, but I have layered onto that all these other skills. And so to start with, if we're really going to look at pain neuroscience, who needs it, who doesn't, when we use questionnaires, for example, like the pain catastrophizing questionnaire, we do have some good evidence. Traeger's research study, I think it was 2015 or 16, that showed that in acute low back pain, giving everyone pain education did not change the trajectory to persistent pain, except for those who were catastrophizing, right? And so those who were catastrophizing actually did much better when you gave them pain education. And so we do have some evidence that people who are catastrophizing, which is a normal phenomena, like let's not make that pejorative or judgmental in any way, shape, or form. I always say to my patients, we all catastrophize, right? That's normal. If I sprain my ankle today, I'm going to start to freak out a little bit and go, I've got to teach tomorrow. I've got to see patients the next day. Like, how am I going to get through this? So catastrophization serves a function, but when we get stuck in that mode, it actually is highly connected with persistent pain. And so we do have research that catastrophizers, people who are kind of freaking out about their pain, do much better with pain education, or people who are fear avoidant. So using the Tampa scale of kinesiophobia, for example, which isn't a perfect scale, but it's the best one we have for fear right now. Maybe the fear avoidance behavior questionnaire. That's the one I'm thinking about. I don't use it because the work component, I don't see so many WSIB anymore, workers' comp. So again, when we use a screening questionnaire, it helps us to tailor what the person in front of us needs, right? And I always use the example of my daughter-in-law, actually, who had chronic low back pain for about 4 years. And in COVID, at the beginning of this year, she was really suffering with this back pain. She had gone to see a chiropractor. She lives about 3 hours away. I had sent her to a couple of different clinicians. She wasn't getting any better. And finally, I said to her, hey, would you like me to take a look? I'm going to treat you like a patient. I gave her all the questionnaires, and I just started from scratch. Because, we do what we do with a lot of friends and family. We just kind of jump in and give them a suggestion and kind of leave again. So I actually treated her like a patient this time. And what blew me out of the water, and she knows we've actually recorded her session, so she's okay with me talking about this, but she's a beautiful 26-year-old, vivacious, gregarious, outgoing phys ed teacher who was starting to become very fearful about participating in her phys ed classes because of her back pain. And her catastrophization was in the severe level. She was convinced at this point after 4 years that she really needed surgery. And so what we had to do was a lot of pain education with her. I would never have guessed, Joe, that her catastrophization was that severe unless I had actually measured it, right? And so I think when we use questionnaires to really help us profile the person in front of us and figure out, are they avoidant? Are they fear avoidant? Are they experiential avoidant of activity? Are they catastrophizing? Are they stressed? Are they depressed? Again, we look at Timothy Weidman's work from McGill, who looked at the strong comorbidity between depression and musculoskeletal pain, right? 25 to 50% of people with MSK pain have comorbid depression. And, I think there's mounting evidence that if someone has comorbid depression with their pain versus comorbid catastrophization, perhaps we need to address that in a different way to desensitize the nervous system. So I really believe that just as we may have, what do we have, 16 special tests for the shoulder? Maybe there's more at this point, right? Why do we have so many special tests for the tissues, which most of them aren't reliable and valid tests either? And yet we won't use reliable and valid questionnaires to assess the sensitivity of someone's nervous system and help guide our treatment process.
So my take home from all of that, and it's wonderfully said, is for the practitioners who are starting to use evidence-based, really cognitive and behavioral interventions, which is
right.
PNE is a cognitive behavioral intervention,
sure,
is to test, don't guess.
Right.
Because we don't know everything that's going on in that person, both mind and body, with regard to their perception and experience of pain as they come into our clinic. Oftentimes we think we know, like we think we have a good idea, but as you mentioned, this is a family member of yours who you know, who's healthy, who's a physical education teacher, who's used to moving her body and understands the importance of the promotion of physical activity and exercise. Yet, once you tested, this kind of big red flag or big yellow flag showed up that, hey, here's the problem, so to speak. Where if you didn't test, you might have eventually come across it, but it may have taken longer or may not have worked so well.
Yeah.
You also use the CSI for a lot of things. Can you talk about that a little bit?
I can. I'm just going to finish up Emily's story for just a sec, if that's okay, because it's quite interesting. I mean, she'd had 4 years. She had a lot of treatment. And so her two biggest issues from a sensitive nervous system, and we'll talk about her CSI score in just a moment, but was sensory motor smudging, as shown on the Fremantle questionnaire, right? And catastrophization. And once we addressed those two pieces and so I looked at her mechanically first, and she was actually a flexion responder. So I repeatedly flexed her for a week, and she was 50% better just doing that. But we would have got stuck there if we got stuck in the mechanical model, right? And then we started addressing the catastrophization piece and then the sensory motor smudging piece. And in 4 visits, so over a period of about 2.5 months, she was pain-free and remains pain-free at this point, right? And so it really is a matter of targeting the phenotype or the profile of every individual's sort of sensitive nervous system. So then how do we measure a sensitive nervous system? So we've got good evidence. So Randy Neblett and his group in 2013 actually validated a questionnaire for clinical practice called the Central Sensitization Inventory. And it's a 2-part questionnaire. So part A is 25 questions that measure, get patients to report sort of experiential symptoms or physiological responses to a sensitive nervous system. So dry mouth and not sleeping, there's just 25 questions. And so if they score greater than 40 on that question, that part of the questionnaire, we can say with confidence that their nervous system is more sensitive. Okay. And again, that's not a judgment thing. We all sort of come in and out of sensitization depending on life circumstances at any given time, right? Part B in that questionnaire is a list of conditions like fibromyalgia, like tension headaches, like idiopathic low back pain, like depression and anxiety. So sort of conditions that happen alongside pain, comorbid conditions that are highly linked and have been shown by many researchers to be connected with central sensitization or a sensitive nervous system. So the CSI, if they have greater than 40 on part A or 1 or more conditions on part B. And physiotherapists should make note that TMJ is one of those conditions. So how many of our patients have TMJ, right? And the other condition that we see a lot of is whiplash-associated disorder. So if they've had a WOD that lasts longer than the healing time frame of soft tissue injuries, then that is highly connected with the sensitive nervous system. And now you have a jump-off point to start discussing with your patients kind of the nervous system and its role in their pain experience.
And then, so, lots of things I want to talk about. I just got really excited for a second. So then from there, how do you then decide, because we all have these branches of the tree now,
right?
How do you then decide, okay, I need to do pain education, but I need to tag on a caboose to this trolley so we have something that's more impactful for decreasing the sensitivity of that nervous system?
Right. Great question. So again, I think we've got some good evidence-informed sort of basis to our practice at this point. And like you said earlier, sort of that alphabet soup, right? So we have really good evidence behind CBT, for example, that CBT is really helpful for depression and anxiety. And so if someone has comorbid pain and depression and anxiety, I might think about adding some CBT to their program. And I actually have about 60 hours of CBT training myself. And so I do a little bit of that. But when it really comes to doing thought records and kind of that more detailed, kind of getting into that real emotional sort of component of their life, I often will refer to a social worker or a psychologist or.
And I just want to piggyback off what you're saying here. So you have 60 hours of CBT training,
right,
which is actually a lot of CBT training for a non-mental health professional.
It is.
And for people listening to this podcast, so everyone knows, and I'm talking about this more and more and more. So I want to thank you for bringing this up, Carolyn. Cognitive behavioral therapy for the treatment of pain can be delivered by any licensed health professional, just as effectively as a mental health professional, if you've gone through proper training and mentorship with regard to using those types of skills in practice. And that's really, I think I just say that because more and more people ask me, can I do this? How can I do this? You know, why shouldn't a mental health professional do this? And I think a mental health professional should, and they do use this in clinical practice. However, when you look at nurses delivering CBT, OTs delivering CBT, PTs delivering CBT for pain, they're equally effective.
Yeah, absolutely. And we do have some really good evidence behind CBT and pain, right? And so again, it's something that we can incorporate. I think, this is my bias as a physiotherapist, so I'm Canadian again, so that physio versus physical, same thing. So I'm biased in that I really think that we as physiotherapists are primed and ready if we can really get some good skills development in some of those cognitive behavioral type of approaches, that we also can deal with the physical. So that biopsychosocial approach, whereas a social worker or a psychologist, their hands are a bit more tied, right? Yeah. And so it was interesting, Joe, I'm sure that you were at the Boston IASP conference in 2018. I didn't know you then, I didn't meet you there, but you know, I'll never forget Dr. Christopher Eccleston's keynote address when he won the Ron Malzak Award, right? And he said, the time has come where all physical medicine specialists, so physiotherapists, physicians, need to incorporate the emotional, psychosocial components in every interaction with their patients, and where psychologists and social workers need to incorporate the physical embodied sort of component as well. We can no longer separate the individual in front of us and say, well, this is my piece. I'm going to deal with this piece, and that's not in my scope of practice, so I'm not going to do that piece. Right?
Yeah, the way I've started talking to professionals about this, and as you mentioned, I've had the same exact conversation with psychologists about more physical activity during their session.
Yeah.
Instead of sitting down in a chair across talking from someone, which is I actually think I've learned that that's actually a larger scope of practice shift than what we're experiencing as physical therapists, which is just so interesting to me.
Yep.
But we have to overcome our own fear avoidance as practitioners to change and start to use these interventions in clinical practice.
Right. That's a huge barrier.
Yeah. I mean, as I teach this, and you know, I have an ACT course, as I teach this to professionals, they love it. And of course, as you go through any type of cognitive intervention, you kind of, in a certain way, apply it to your own life context first, and that's completely fine.
Yeah.
So they get over that barrier.
Yeah.
But they don't see like the second wave over the first one is, oh, now I have to overcome the fear of using this in practice, which I really make an attempt to normalize that for people, because when you first graduated physical therapy school, I graduated in 1997.
Yeah.
A very biomechanical based schooling like we all had back then, if you're a little bit older like me.
Yeah. And me.
Right. And even then there was a fear to see your first ACL patient, fear to see your first patient with a coronary artery bypass, fear to work with the first pelvic floor patient you've ever worked with. You know, we overcome those things as professionals. So we are at a place now where we're learning how to overcome the psychosocial aspects. Okay, so let's loop back around to where we
were we?
I want to back up just a little bit there. So you start to use some cognitive behavioral therapy if depression scores are high.
Right. So, we're talking about depression. So, or let's talk about, and this will link back to our psychology colleagues as well, right? What do we have great evidence in depression for? Walking, right? We need to get our patients walking. It doesn't have to be walking. What do they enjoy? Swimming, cycling. They need to get their heart rate up to that 65% target heart rate for 30 minutes, 5 or 6 days a week. We have great evidence that depression is reduced by 50% when people do that, right? Our psychology friends can recommend, colleagues can recommend walking to their patients, right? We've got to include sort of that component. So, and depression, World Health Organization actually says as well, 2 to 3 times a week of resistance training for depression has really strong evidence behind it. And I think you actually interviewed someone on your podcast with regards to that. It was a brilliant interview. We also have good evidence around yoga and depression. So can you see how our job is really to get our patients moving in a non-threatening way. So that's a really important component. They have to love what they're going to do. So again, engaging them in what's important to them, that value-based kind of approach that I know you really talk about in ACT. And then start to be a little bit more targeted around someone who's depressed probably needs to be activated in some way, right? And someone who's really anxious probably needs to be calmed down in some way. Right. And so maybe they are going to start a worry journal. Maybe they're going to start an alternate nose breathing practice for 5 minutes, 4 or 5 times a day. But when you start to profile their presentation as a sensitized, as part of their sensitized nervous system, you can be more targeted in your approach. But that also means, as you've already said, we need to develop more skills in a broader area, including CBT and ACT and motivational interviewing and different breathing techniques. And so really having a much more broad psychosocial sort of toolkit to draw on so we don't default back to our biomechanical, biomedical kind of approaches.
You mentioned cognitive behavioral therapy.
Mm-hmm.
The other thing that we often talk about in this podcast is mindfulness, which in the scientific literature has started to kind of get taken up by psychology, although I think one of the nicest things about mindfulness is that it's not psychology, but has principles of psychology that can help people. Where does mindfulness fit into a P&E plus approach for, I mean, I know, of course, you're a pelvic health expert, so there's probably some certain applications for that, but where did we start to tag that on to P&E plus?
So is anyone ever really an expert? I would say I've got expertise in pelvic health. I am still learning as we go. So it's interesting. I'll tell you another little story. I picked up a patient from the East Coast in Canada who had 20 years of pelvic pain, and she was being seen by a lovely physiotherapist, very biomechanical at that approach. She came and took my course on using distress questionnaires to help to profile the nervous system. And she said to me after that, I've got this really complicated patient I would love you to see. And I said, you know what, you can do this. You've got the tools, go and try, right? And she's like, okay, I'll try. But her concern was that this gal had so many previous failed attempts that if she changed directions and she failed again, it would become more of a nocebo for her again. And that was a reality. So I said, play with it for a couple of weeks. Call me. We can do a Zoom kind of co-treatment if you really want to. And so she did. She called me in a couple of weeks. And so we did a few co-treatment sessions with this gal. And what's really interesting is that she had waited sort of about 6 months before I saw her with her therapist. She had spent about a year in a chronic pain management program in a hospital that she had waited 2 years to get into. And it was very much focused on graded exposure and graded functional activities with the physio and mindfulness with a psychologist. She spent 6 months doing one-on-one training with mindfulness with a psychologist. And she left that program absolutely no better than she started. So I also saw her after she did 6 months of mindfulness. So I didn't get any pre-scores prior to her doing that. But my observation when I saw her and I gave her sort of 6 or 8 questionnaires that I standardly use with patients is that actually she was not catastrophizing at all. And what I look for in the pain catastrophizing questionnaire is the rumination component. I really like to use mindfulness for people who tend to just do a lot of rumination or are very hypervigilant, okay? Because we know as well that mindfulness calms down the front insular cortex, makes it thicker and stronger and more resilient. And that's the area that tends to become more active in hypervigilance and rumination. So she had spent all this time doing mindfulness. Her catastrophization scores were absolutely normal. But what was not normal for her was her sensory motor smudging scores. Her Fremantle questionnaire was really high. And so that's what we actually addressed. We did a little bit of pain education so she could link sort of the pain system. And she knew some of that already. But it was really about addressing more specifically what she needed, which was sensory motor reorganization. So we had to find novel movement practices that were non-threatening for her to start to work on that piece. And then she started to see functional gains, which was beautiful, right? So that's who I tend to use mindfulness for, is people who are quite stuck in kind of that rumination or hypervigilance mode. Or just even someone who's stressed and really kind of is ADD, ADHD, busy type A, and they really just need to kind of calm down and become a little bit more centered kind of in their day-to-day experience.
And then how much have you started to use acceptance-based approaches in clinical practice, which again are at times weaved into traditional cognitive behavioral therapy in some way, definitely weaved into mindfulness. Yeah. I actually think that an effective P&E practitioner or someone who's trained to use P&E, they actually probably haven't quite, some aren't aware how much acceptance work they're actually working in there.
Right.
But it's present there.
Right. Absolutely. I would say that I weave. So I've done some work with Kevin Voles in acceptance and commitment therapy. I haven't done nearly the extensive training in acceptance and commitment therapy as I have in CBT. But I tend to use more ACT-based principles in patients who are really maybe more functionally disabled. So if my patient is actually with persistent pain, is actually quite they're still participating in their day-to-day activities, but with pain, I probably wouldn't use ACT for someone like that. But I'm going to use ACT for people who are starting to not function in their day-to-day. So kind of the experiential avoidant patient that we've chatted about. That is the type of patient I might use ACT more with.
Right, and that's exactly right. High experiential avoidance. Yeah. High pain avoidance. Yeah. Low physical activity, low ADLs. That's typically the group that responds well to ACT. Yeah. And which is great because we actually have a decent amount of evidence in that range to phenotype, as you mentioned, that type of person. Right. If that's the type of person you're seeing, based on, let's say, the chronic pain acceptance questionnaire, there's an 8 and a 20 you can use as part of this battery of tests that we're talking about, then it starts to tell you, okay, I need to work towards more mindfulness and acceptance-based approaches with this person, at least in the beginning. Yep. And then we can move on to other things that we're talking about. Yeah. Yeah.
I always talk about ACT a bit like, if a patient is going on to this highway of change I talk about, right? And they're on the on-ramp and they haven't been active, they haven't been engaged in life a lot because of their pain. ACT takes them into the slow lane. ACT gets them on the highway, right? And then once they're on the highway and they get used to driving again and get used to doing things in day-to-day life, now maybe we can spend a bit of time in the fast lane and see if we can actually change their nervous system a little bit more and look at maybe desensitizing their system, which is kind of how I might talk about that piece. And maybe they need to go back in the slow lane for a while again and they go back and forth. So it's never a straight line, as you know, Joe.
Right. Yeah. And we're not saying that, hey, high experiential avoidance, you have to use ACT. You can't use P&E or you can't use cognitive behavioral therapy. Some of the cognitive processes that are at work here are at work in no matter what type of intervention you're using, even if you've never trained in a cognitive intervention. Right. Because it's just wrapped up somewhat in general counseling and communication, or I should say effective counseling and communication that we're using with patients.
Right. Yeah. When physiotherapists talk to me about using CBT in their practice, I will say, you're already doing it. right? You're already changing thoughts and beliefs and behaviors. You just haven't put the structure around it per se, right? And so how is, when you put structure around it, you just become a more skilled deliverer of that system. That's all, right?
So the $1,000,000 question, as a physiotherapist, have you in the past or currently, or have you played with, and is there a place for physiotherapists just to have one session or multiple sessions where there's no exercise, physical therapy, or manual work, and you're dedicating just that time to whatever it is, whether it's P&E or ACT or CBT or mindfulness or whatever alphabet you want to add to this.
Right. Absolutely. I would say that as a physiotherapist, I touch most of my patients still. Right. So not necessarily every session, but even just, and so and again, I'm a pelvic health physio. So if I think about what I do kind of, from a pelvic health perspective, there used to be a day. So I've been practicing pelvic health for about 20 years. I've been a physio for 33. There used to be a day where I used to talk about releasing trigger points, right? And doing kind of manual therapy, tissue fixing kind of processes. I no longer talk like that. So we've done some research, and there's some building research that says in pelvic health for sure that when there's tenderness on palpation, it's a top-down process. It's the sensitive nervous system guarding a very important part of the body. And so if I do some internal work, what I say to my patients is, I'm having a conversation with your nervous system right now. And again, that means that I have to be non-threatening. That means we first have to have a very strong therapeutic alliance. That also means that gone are the days where I'm assuming that in that first session, I need to do an internal exam, right? By the time we've had a really good conversation about their story, there usually isn't time in the first session at this point. So where my subjective eval used to take just maybe 20 or 30 minutes, sometimes it takes that full hour. But that leaves that next half hour when they follow up with me again to do a really careful, thorough, consensual exam where they're not being threatened by my touch. And if they are, then we need to sort of unpack that piece as well, right? So whereas I touch, I would say, all my patients at one point, there are many sessions where we are really just problem solving, digging a little bit deeper, looking at sort of behavior change and what that might look like, taking a much broader lifestyle approach, which I know you also talk about, looking at nutrition, looking at many factors that are involved in sensitizing the nervous system. And that takes a big step to be comfortable with that, because that's not how we're trained, right?
Yeah, that was my next question. Did that just develop naturally on your part, or was it more someone helped facilitate that in your practice change, or was it like, hey, I'm just looking so much at all the psychosocial variables that I really need to learn about my patient's experience with their pain first, and then we can move on to these other aspects of it. Because I think what you're saying is developing that bond with someone, which is part of that psychosocial, will help later on with some of the interventions that cause more fear and anxiety for people, such as touch, exercise, physical activity, pain exposure, graded exposure, et cetera, et cetera.
There's a psychological study, Lambert, 1992, and again, it's in the psychology world, but there's been some other studies that have gone on to show that the same thing happens in physiotherapy, that the outcome, 30% of the outcome is dependent on therapeutic alliance, right? And so 15% of the outcome depends on the intervention you use. And yet we spend so much time learning the interventions, and we don't spend a lot of time really learning how to really connect with the person in front of us and taking that time to really connect. Joe, I send every one of my patients a 14-page questionnaire that they fill out before they come to see me. And some therapists just roll their eyes and think, oh, like I can't do that to my patient like that. It takes them about 20 or 30 minutes. And after the first session, and many of those first sessions, especially with complex pain, are just talking, working through all of the information, the story, the questionnaires, putting the story together. The majority of my patients will sit back at the end of that and say, wow, I knew I was in for a different approach as soon as I filled out your questionnaires. I so appreciate the fact that you actually took the time to learn about me as a person. And I feel like you understand my pain problem better than anyone has yet to date because you took that time. So where we think as clinicians, patients aren't going to value that, in fact, the opposite is true.
Yeah, that's exactly right.
Yeah.
That's 100% accurate. And people say, how do you give people all that paperwork? And I say, well, here's how I do it.
Yeah.
If it's someone who's coming into the office and their appointment's at 1:00, I ask them to come in at 12:30, and they have a half hour to sit in the treatment room, to relax. I give them a cup of tea, and they sit down with the paperwork and they fill it out while I'm finishing up with my other patient. If it's virtual, my assistant is sending them that packet of paperwork. And in the email, it says, please take your time over the next week to sit down with this paperwork, either in one sitting or maybe a couple of times, because there's a lot here, and send it back to us because it's important for your continued care. And there's lots of different ways to do it, but those are just two ways to help people
100%.
negotiate, a lot of paperwork. But like you said, once people get a different sense of, wow, this person actually really is interested in what's happening with me.
Yeah. I mean, we start with, we take a whole person approach. And as part of that whole person approach, again, it's how you set it up, right? And how you kind of introduce it, as you say. So there are ways to do it. It's our confirmation bias that suggests our patients will resist that kind of piece. I would say I send it ahead of time with the same sort of provisos that you talk about. And I would say I get 90% completion rate of that questionnaire beforehand. And again, it is over and over again appreciated. Because but then I think nothing's worse, Joe, than you give this questionnaire and then you don't talk about it and then you don't integrate it. And then they're like, well, why did I fill out all of that information, right? And I think to some extent, this is why we as physical therapists are challenged by questionnaires, is because we've used them historically as outcome measures. And it was kind of like, no one gives a crap, kind of like it was just, that type of thing. It really didn't change our treatment intervention. Whereas when we use questionnaires to assess the sensitive nervous system, it is like doing range of motion, special tests, palpatory tests that I would do for the physical piece. I don't know how to address their sensitive nervous system if I don't use questionnaires. End of story. I just don't know. Right?
That's why if you come to my website at the Integrative Pain Science Institute, on the homepage, there are 5 evidence-based questionnaires that are public and you can download them. Those are just a taste of what I use and a taste of what Carolyn is talking about. But I find when I start training professionals, as we mentioned before, they're not measuring anything. So we have to measure before we can start to work with our patients and really dive into their lived experience. Carolyn, it's been wonderful talking to you about Pain Neuroscience Education Plus and everything that you're doing in clinical practice. I mean, 30 plus years of practice, you've seen how our profession has changed and how we're now able to serve people on a completely different level. And people are going to want to know how they can follow and learn more about you. So tell us where we can find you.
Awesome. So as I said, I'm Canadian. In the beginning of 2020, so just as COVID hit, we started a new teaching company. And so it's actually myself and my daughter, who's a physiotherapist, and my daughter-in-law has actually helped run kind of the business end. So it's a bit of a family company, which is a lot of fun at this point. It's called Reframe Rehab. And the idea behind Reframe Rehab is to break down the barriers between pain science education, pelvic health, and chronic musculoskeletal pain. Because right now, as clinicians, we live in silos, right? We identify, I'm a musculoskeletal therapist, or I'm a pain science therapist, or I'm a pelvic health therapist. And our research over the last 5 years has shown that, you cannot work in silos and effectively treat the person in pain in front of you. So that's really our goal. So you can find us at reframerehab.com. You can follow us on Instagram. We have a closed Facebook page where we talk about all things biopsychosocial, and we'd love to have that conversation with you.
Excellent. So I want to thank Carolyn for joining us this week on the Healing Pain Podcast. Make sure you check her out at reframerehab.com where you can learn more about her. And make sure you share this episode with your friends and family on Facebook, Twitter, LinkedIn, or whatever Facebook group. There are thousands of practitioners who are interested in learning about pain neuroscience education. I'm Dr. Joe Tatta. It's been a pleasure as always, and we'll talk next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.